definition is the new finding of a hypercalcemia after 6 months when a patient was operated successfully. So the definition considers the calcium level. This is very important. It does not consider the PTH or the parathyroid hormone level. When you are confronted with a recurrent primary hyperparathyroidism, you should always confirm it, not just send them to the surgeon, but first confirm it and repeat the measurement and take the albumin adjusted calcium, or better the ionized calcium. And then you will see if the PTH is elevated as well. And then when you have the diagnosis, you can send them to a center for operation. The prevalence is about 2% to 10%. We would say that there are some recurrent primary hyperparathyroidism patients after 10 years also. So we have a long-term follow-up, or we would consider to measure the calcium level 1 time a year. And there's a special group of patients, of course, younger patients. If you have a primary hyperparathyroidism in younger patients under 30 years, you should consider the molecular testing, because they could have a multiple endocrine neoplasia, which goes along with a recurrent primary hyperparathyroidism more often. Yes, a very good question. We must say that there are about 1/3 of patients who have elevated parathyroid hormone levels after successful operation of a primary hyperparathyroidism. The reason is not really clear, but it does not automatically goes along with a recurrent primary hyperparathyroidism. So this is a special case, the PTH elevation in the normal calcemic patients after operation. We would say that we not routinely recommend the PTH measurement after operation because of this case. It will always make things difficult. So we recommend the measurement of calcium level. And if it rises up or increases, you can measure the PTH level, but not vice versa. If you are confronted with this case, a higher PTH and a normal calcium level, you should exclude secondary hyperparathyroidism problems like, for example, vitamin D deficiency, because this could also rise the PTH level without being an illness. If you're not quite sure, you might consider associated calcium load testing, so we could see if the suppressibility of PTH is still there or not. We would say if there are patients, for example, who have a more upper or whose calcium serum is towards the upper normal level of the range, of the reference range, it could be a sign for a recurrency. So you have to monitor them more closely, for example, 2 months or 3 months. And if you see in the long-term follow-up or in the follow-up that the calcium really rises, you have the diagnosis.